Good afternoon. We will discuss the protocol-based management for diabetes. The format of the presentation is that we will first describe the basic theory regarding diabetes, and then discuss the contextualized factors related to diagnosis and management of diabetes in Bhutan, and then the protocol-based management for diabetes in the country. Just a theoretical discussion here. Diabetes is a problem of glucose homeostasis, where at the end of it, you end up with very high glucose levels in the body, which is not good for the organs. As per the American Diabetes Association, these are the classifications of diabetes. We have type 1, 2, diabetes due to other causes that includes steroid-induced or pancreatitis or related to genetic issues. And the third component, the last component is we have this gestational diabetes. So the diagnostic criteria and all are a little bit different for gestational diabetes. Though we have these four classes of diabetes: type 1, type 2, diabetes due to other causes, and gestational diabetes. The majority of our patients will have type 2 diabetes, and then the age of onset of type 2 diabetes is found to be becoming younger and younger. And the majority of the patients with type 2 diabetes are usually asymptomatic at presentation, but some of if they present with classic symptoms, this would be polyphagia. You have more hunger, polyuria, passing more urine, more thirst. And for an adult person, after you go to sleep in the night, you should be able to sleep all throughout the night till the morning without having to go to the bathroom to pass urine. If you have to go out and wake up and pass urine, that means you have nocturia, you have blurred vision or weight loss. So these are the classic symptoms. So we will have, if a patient comes with a very classic asthmatic symptoms, you will have to identify them. But mind you that the majority are asymptomatic at presentation. What are the risk factors? The risk factors is somebody who has family history of diabetes, who have higher BMI, sedentary lifestyle, and if you have high blood pressure, it adds as a risk factor to your diabetes. If you have dyslipidemia, it increases your risk of diabetes. Somebody with gestational hypertension, the older you get, and then impaired fasting glucose or impaired glucose tolerance. We'll discuss this in a separate slide. How do we screen for diabetes mellitus? This slide has been introduced, and this component has been introduced to the 2025 revision because of late there has been a lot of screening programs, NCD screening programs that's happening all around the country. Now, screening programs are usually community-based programs, and the cutoff values with capillary blood, where we do screening with capillary blood glucose. The cutoff values for capillary blood glucose that you check with your glucometer is a little bit different from the venous blood glucose, but for the purpose of our protocol, we have said that it is similar to that of venous blood glucose. Why? Because we want our field staff to remember only one set of numbers to screen for diabetes. And diabetes can only be screened with capillary blood sugar is only for screening, and it cannot be used for the confirmation of diagnosis. So for you to diagnose, so if you have screened the patient for diabetes, and if it's high in a screening setting, then you will have to direct the patient to a healthcare center to perform a venous blood glucose testing. So what are the tests? For the diagnosis of diabetes, there are 4 tests that we can do. First one is fasting plasma glucose, where fasting is defined as having no calorie intake for the last 8 hours. The second one is 2 hours plasma glucose. That is done with 75 grams of oral glucose tolerance test. Now, in many hospitals, OGTT is reserved only for patients with pregnant mothers at the MCH unit. And if it's not available, then you can test the 2-hour plasma glucose after the patient has taken a standard normal diet. The third testing that you can do is any random plasma glucose, that is venous blood glucose in a random plasma glucose. And this can be considered only in patients who has hypoglycemic crisis or any obvious asthmatic symptoms. And the fourth test is would use for diagnosis of diabetes is HbA1c, and the values are given here. However, the very strict criteria for the use of HbA1c for diagnosis of diabetes is that the test method for HbA1c has to be the same test method that is being used in the DCCT trial, or a test method that has been certified by the NGSP. However, all the diabetes key, the HbA1c testing that is available in our country does not follow the standard procedures, or they do not meet the standard criteria. Therefore, the only tests that are available for us to diagnose or for confirmation of diabetes are fasting plasma glucose, 2-hour plasma glucose, and random plasma glucose. And one small message, we have a very common way of saying that fasting plasma, fasting blood sugar or postprandial blood sugar, we use the term sugar. The term sugar refers to all kinds of sugar, but here what we are testing is only glucose. This is the study that says that looked into HbA1c testing in our country, and then it does not meet our standards. To confirm the diagnosis of diabetes, you require two abnormal screening test reports, two screening tests, either on the same sample or two separate samples, which means that two abnormal tests and two occasions, which means both fasting and plasma for fasting and postprandial should be abnormal and on two separate samples. And then the repeat testing should be performed as soon as possible when the next opportunity arises. Now, this slide is quite important here. For you to diagnose diabetes, fasting has to be more than 126, and the postprandial plasma glucose has to be more than 200. But what if one of them is abnormal? Now, for example, if the fasting is normal and postprandial is just elevated, 140 to 199, it does not cross the 200 value. So in this condition, we will call it as impaired glucose tolerance. This means that whatever glucose that you have taken in, at the 2-hour level, you are unable to tolerate it. So IGT. The second situation is then in the fasting state, you have a glucose of your fasting plasma glucose is elevated 100 to 125, but it does not cross the threshold of 126, and your postprandial plasma glucose is normal. So in this case, you will call it as impaired fasting glucose. Why? Because only the fasting plasma glucose is abnormal. Both of these conditions combined is called as prediabetes. And then if your HbA1c is done with a standard method, this is the cutoff for prediabetes. Now, how do you follow up patients with prediabetes? You will have to provide your lifestyle modifications, and then starting off medication is not recommended as per guideline. And then you will have to follow these patients up with a formal screening method, fasting and postprandial plasma glucose testing at a 6-month interval. Now, in the 6 months, majority of the patients usually at the end of 6 months, they turn out to be full-blown diabetes if you don't adopt the lifestyle interventions in between the 6 months. Now, what are the methods to prevent diabetes? Moderate level of physical activity, healthy diet, and then person-centered goals for weight reduction or to maintain healthy BMI. And for management of diabetes, this is particularly important because there are many ways to encourage patients with diabetes to take self-control. That is why, for example, this is in Genifo Hospital, we have certain periods where we call all the patients together and then provide health education at the same time. Or if time and resources permit, you can provide the same level of health education to every patient, but to save our time, we call all of them together and do it from periodically. And self-monitoring using glucometer is recommended if and wherever possible. What are the glycemic targets? For the fasting plasma glucose, 80 to 130. For the postprandial, less than 180. For the monitoring of your glucose control, if in best scenario, if you are able to do venous blood glucose all the time, do it. If you are unable to do your venous blood glucose for the monitoring purpose, you can monitor it using capillary blood glucose, which means using the glucometer, and if HbA1c is available. Now, Here, why we have listed all the three is because based on your setting, you select whatever is available. How do you monitor for complications? For the heart, you do ECG, or for the kidneys, you do a creatinine or urine protein or albumin. For the eyes, you do a fundoscopy. For diabetes, you will have to do a foot examination, and then you will always have to see whether the patient has met the target for your glucose. For diabetic foot evaluation, this is the stages as how the diabetic foot will progress from a simple abrasion ulcer to a very difficult ulcer to treat. These kind of patients usually require a long hospital stay, and then the wound healing is very slow. What are the symptoms? Redness, swelling, or there is this breakage on the skin, itching, dryness, and pain and stiffness, or there can be ulcers or blisters. Usually they are painless, and these usually appear on the pressure points. Now coming to our protocol for diabetes. The protocol has a similar structure. The blue part is for your diagnosis, and the green part is for your management. In diabetes, we are expecting two complications. Either the sugar can be too high or too low. At the bottom, we have given the targets. We have one yellow box for your lifestyle, the set of advice that you give to the patients, and we have one important box at the end in the gray box that tells you how to test your fasting and postprandial plasma glucose. This is to standardize everyone and to avoid confusions. This is the protocol for screening and management of diabetes. This protocol is version 3, that of January 2025. Here, there are two steps in screening that we have introduced. First one gives you the criteria for screening. So you have to provide opportunities for people to screen for diabetes if they have symptoms of polyuria, polyphagia, polydipsia, loss of weight. If somebody is older than 40 years, somebody who has already diagnosed with hypertension, dyslipidemia, or overweight, and first, if they are older than 30 years and if they have a first degree relative with diabetes, or in women who have had gestational diabetes. Now, in a screening setup, you can do fasting capillary blood glucose. That would mean that you meet the criteria 8 hours of low calorie intake. Then early morning you come and then you do the capillary glucometer testing. And then here, if the value is less than 126, then you have to follow this patient up yearly. The numbers are similar for both venous and then venous and capillary blood glucose. For the postprandial, if the fasting capillary blood glucose is more than or equal to 126, meeting the criteria in terms of if it were a venous blood glucose, then you will refer it to a secondary level care. Okay, going back. So screening for diabetes can be done using fasting capillary blood glucose, and if it is no less than 126, you follow it up yearly, and if it is more than 126, you refer it to a secondary level care for venous blood testing. At this level of screening, you need not have to do a postprandial at a 2-hour glucose testing using a glucometer for screening. Now, at the secondary level care, you will do a fasting plasma glucose. If you have oral glucose tolerance test, and if the stock is enough for you to test it for general population, please do it. Or if you think that if you have an opportunity to indent for more anhydrous glucose, you can do it. But as of now, you can do it with a standard with a standard meal. That would mean that for 2-hour plasma glucose testing, you ask the patient to eat the same breakfast that the patient eats at home, and not a different kind of set like from the canteen of the hospital on that day. Or in a person with overt osmotic symptoms, if the random plasma blood glucose is more than 200. Now, from all these 4 tests, there should be 2 frank abnormal tests on 2 occasions. But the common testing that we do is fasting and postprandial plasma glucose. Now, if both of them are normal, fasting less than 100, postprandial less than 140, you follow it up yearly. If one of them is abnormal, if the fasting is elevated or postprandial is elevated, this group category, and the other one is normal. If the fasting is elevated, postprandial is normal, or If the fasting is normal, if the postprandial is elevated, if only one of them is abnormal, if it meets the criteria of pre-diabetes, you follow them up 6 monthly with a formal fasting and postprandial blood glucose testing. Now, if the patient has both fasting and both postprandial abnormal on 2 occasions, then you will have to initiate treatment directly, and it will go into the green box. How how do you initiate the treatment here? For the initiation of the treatment, it will be done at a secondary level care, where you will initiate the treatment with metformin 500 milligrams BD, and at the same time, you will do the baseline screening with lipid profile, liver and renal function test, the ECG, urine routine or urine albumin fundoscopy at the possible earliest stage. Now, if the patient is getting diagnosed at a referral hospital, maybe you can get it done at the same setting. But if it's getting at a district center, and then if you have to send it for a fundoscopy to a tertiary level center, or where there's this eye center, then you can coordinate at the earliest possible date. All these set of reports has to be evaluated by the medical officer, and then you will have to individualize the treatment. This would mean that whether the patient, you would like to add pioglitazone, insulin, or glipizide, or like dapagliflozin, based on the patient profile, you will individualize the treatment, and then you will send the patient back to the primary healthcare center for the follow-up. Now, if the fasting and the postprandial at the primary if at a primary healthcare center, when you are following yourself, when the patient is being followed up at the primary healthcare center, if the monitoring can be done using for fasting and for postprandial plasma glucose, you can do it using glucometer. So for both instances, in this case, you can do it with glucometer. If both are within target, the target given here, fasting between 80 to 130, postprandial between 140 to 180. If both the fasting and the postprandial are under control, then you will follow this patient up 2 monthly and provide advice for self-care. That would mean to avoid hypoglycemia, to carry a chocolate, so many other things. This would mean that you can give medications up to 2 months. And the same logic applies here, that if you start giving medications for more than 3 months, you will miss the opportunity to intervene, and this will directly impact on the control rate on your NCD dashboard reporting. If fasting and postprandial plasma glucose are not under target using glucometer, then you should follow this patient monthly, and you will have to titrate the medication. And once if it's under control, then you will send the patient back to the primary healthcare center. But if it's not under control, you can consult the higher center. Now there are a few concerns here. What are the conditions where the specialists will have to be involved for diabetes care? There are very few conditions where the specialist will have to take care of patients with diabetes. One is stroke, retinopathy, heart disease, somebody with chronic kidney disease or raised creatinine level, somebody with proteinuria, and where blood glucose is not getting controlled despite all your measures. So, as discussed in the hypertension protocol, the majority of the patients with diabetes or hypertension should be able to be taken care of at a primary healthcare center or in a district center, or if you're discussing in the context of a tertiary healthcare center, in the NCD clinic or in the general OPD. And there are very few conditions where patients with diabetes will have to be seen by a specialist. Now we will go to the advices that we will have to give to the patients. Now at every visit, the advice that we will have to give is that we have to provide advice on the lifestyle changes. For tobacco and alcohol, we have to be very consistent with everyone will have to be consistent with the advice that we're giving. You'll have to stop smoking, stop alcohol consumption. You will have to maintain a normal BMI. And then for the diet, you will have to consume low glycemic index food and avoid foods with added sugar. And for the physical activity, moderate physical activity, 30 minutes, 5 times a day, 5 times a week. Okay, 5 days a week. Now we will go on to discuss the emergencies. Now, in diabetes, you can have hyperglycemia, and hyperglycemic emergencies can be one of the following, with one of the following symptoms. Now, if a sugar with somebody with sugar more than 250, with shortness of breath, fever, vomiting, abdominal pain, decreased urine output, altered sensorium, and somebody is having a low BP and pregnancy. Now, from a primary healthcare center, here at an HA level, we are not asking them to identify what kind of emergency and not to, here we are just asking them to load these patients in the ambulance, give normal saline 1 liter over 2 hours and continue 1 liter every 4 hours so that you calculate the time duration that is required to reach the secondary level care, and then you put the patient on add IV fluid and then send the patient to a secondary level care. Now, at the secondary level care, it is up to the medical officer to evaluate and then manage the complication. And at the same time, if it's a new patient, the diagnosis will be established. They will do the baseline evaluation, establish the patient on the treatment, and then send the patient back to the primary healthcare center for follow-up. The second set of complications that we may encounter is that they can have hypoglycemia. So if the patient is conscious and with symptoms of dizziness, sweating, hunger, you can give this oral sugar in the form of teaspoons of sugar or chocolates or some juice or fruit juice. Or if the patient has this loss of consciousness or altered behavior, then you will have to give ARNI. Or if the sugar is less than 70 mg per dl, then you will have to give dextrose 25. And then you'll have to consult the secondary level care or your nearest center and try to optimize your oral glucose lowering agents or your insulin. Now, the box of hypoglycemia, mentioning the hypoglycemia, appears separate and it is not connected, because even if a simple hypoglycemia can be easily managed, and any titration of medications can be done through phone. And the last part of this protocol contains this box on how to provide advice on how to test for sugar in your hospital. Now, if it is for fasting plasma glucose, there should be no food or drinks for minimum 8 hours. And the maximum we would like to advise through our protocol is to 10 hours. This means that you need not keep the patients fasting for a very long period of time, causing unnecessary trouble to the patients. So you ask no food, no calories for 8 to 10 hours. Now, in this case here, if a patient is also having hypertension, they can take hypertensive medications or any other medications with a cup of water, and you have to make it categorically clear that you are not allowed to take any tea or milk tea or anything like that, or any juice that contains calories. Now, if you're doing an oral glucose tolerance test, then you'll have to, when the patient comes in, you'll have to dissolve the 75 gram of anhydrous glucose in a glass of water. Or if you have the standard measuring cup in your unit, you do it in that. You make the patient consume it and then wait for 2 hours and then draw the sample for the postprandial plasma glucose. Now, for follow-up patients, for you to test the postprandial plasma glucose, you'll have to tell the patients to take the oral medication first. Fasting has been done. For the postprandial plasma glucose, you take the oral medications, you eat your usual breakfast, wait for 2 hours, and then draw the sample. If the patient is having insulin plus oral medication, the sequence will be that you take the insulin and the medication, wait for 30 minutes for the insulin to act, then eat your usual breakfast, wait for 2 hours, and draw the sample.